Tonight's program, as you can see, is MS Neuro TV, and my name is Stuart Schlossman. I'm president and founder of MS Views and News. It's an MS Views and News event, and we have Dr. Matt Kay. And Dr. Matt Kay is a neuro-ophthalmologist with an L, as everybody seems to forget. Okay, and tonight's topics, we're going to be doing visual issues with multiple sclerosis. And Dr. Matt Kay is, well, he's been in South Florida for 30 years practicing. And I know he's a good doc because he's my doctor, right? So he's got to put up with me at least once every other year. And he's also a board member with the MS Views and News Medical Advisory Board. So we want to thank Dr. Kay, and let's get started. He's going to speak for about 30 minutes. So Dr. Kay, take it away. Way to go.
Thank you, Stu, for the kind introduction. So I'm an ophthalmologist by training, and then my fellowship was in neuro-ophthalmology. And tonight we'll talk about the aspects of MS that I encounter virtually daily in my practice. So moving to the slides. Neuro-ophthalmology is a subspecialty of neurology and ophthalmology, which addresses neurologic conditions affecting not only vision, but the eye movement. So half my practice is those who see too little. People have a problem with the way vision's coming in from the eye and transmitted to the brain. And the other half of my practice is those who see too much, being those that have double vision because their eyes aren't coordinated together. And next. So I'm talking to an audience of either patients with multiple sclerosis tonight or family members, so you all know a lot about it. And but what I will highlight is the neuro-ophthalmologic manifestations can be as frequent as 50% of the initial presentation of MS. Whenever I talk to a group of patients with multiple sclerosis, I know that at least a quarter of you, if not more, had optic neuritis or inflammation of your optic nerve as your initial presentation of MS, and may have thought nothing of it, just you're going to the eye doctor because you had some pain when you moved your eye and lost some vision. The next thing you know, you're getting a workup and being told you have a neurologic condition. As many as 70% of you may develop some neuro-ophthalmologic manifestation of MS during the course of your condition. So when a patient comes into the exam room with me and I know they have multiple sclerosis, I always ask them, do they have blurring, do you have blurring of vision? Do you have double vision? Are pieces of the world missing because you have visual field defects or some aspect of your peripheral field you don't see? Or do you ever have episodes where the world is jumping up and down from something called Nystagmus that we'll touch on briefly later? Next. So by far and away, most common thing we'll see in patients with MS, and I'm sure that many of you are listening tonight have had, is an episode of optic neuritis, and we'll talk about that in a minute. Double vision, there's a couple patterns. There's something called an INO, it has a long name called internuclear ophthalmoplegia, but that's too long to say all the time, so we abbreviated INO. We'll see some examples of that. And that can also be the presentation of multiple sclerosis when we get a young patient coming into the office with a new onset of double vision, no history of head trauma or anything that might have precipitated it. MS is always right at the top of our list of considerations. And then there's a host of other ocular motility problems or eye movement problems leading to double vision. Visual field defects occur less commonly other than the field defects associated with optic neuritis, and but you can have MS plaques affecting anywhere along the visual pathways. And then UTOS phenomenon, which many of you may have experienced, particularly if you've had an episode of optic neuritis in the past, and that's where you have blurred vision or distorted vision when you're exposed to heat. So if you're working out, your core body temperature goes up, you're spending the day on a beach, you can get UTOS phenomenon. And vision usually clears once your core body temperature cools back down. Next. So as a neuro-ophthalmologist, I specialize in every optic neuropathy under the sun, with the exception of the most common one, which is glaucoma. So glaucoma is a condition that affects the optic nerve. It's the most common optic neuropathy, but that's a specialty in and of itself. And then as a neuro-ophthalmologist, I deal with all the rest of the optic nerve conditions, whether it's inflammatory, such as optic neuritis, related to poor blood flow, something we call ischemic optic neuropathy, or from medication toxicity or tumors pressing on the optic nerve. But what we'll talk about tonight is optic neuritis, which is the most common form of acquired optic nerve condition in young patients, and is associated with multiple sclerosis in a significant percentage of the individuals who acquire it. Next. So again, optic neuritis is the number one visual symptom of multiple sclerosis, and in fact, it is the number one symptom of any MS patient. As many as perhaps 25% or so of patients with multiple sclerosis present with optic neuritis, and 50% during the course of the disease. So as many myriad of symptoms you may have, from numbness to weakness to memory issues, what have you, one thing that's incredibly common is as many as half of you can develop an episode of inflammation of your optic nerve during the course of the disease. And if we really look at more subtle ways to assess optic nerve function, you can do what we call electrophysiologic testing, something called a VEP that's often used by neurologists when they're first trying to diagnose multiple sclerosis. Or if you go to the eye doctor and you look at an OCT of the nerve fiber layer, which can actually tell you that whether there's been some thinning or loss of nerve tissue. Perhaps as many as 90% have evidence of optic nerve dysfunction. Next. And in terms of optic neuritis, well, the demographics, meaning the patient population it affects, really mirrors that of multiple sclerosis, and most commonly affects people between the ages of 18 and 40. About 3/4 of the patients are women, and the mean age of onset is 32. Moving on. So what are the features of optic neuritis? Those of you who have had it are aware of it. Those of you who haven't should be aware of it in case you ever develop any symptoms along these lines. So it's a sudden onset of visual loss affecting one eye. It often affects the central visual field, as is illustrated in this little diagram on the right there. And there's pain on eye movement. It's usually not severe pain, although there are some unusual cases where it can be pretty uncomfortable. But usually it's just a mild aching or pulling sensation when you move the eye, because when you move the eye, you've got your eye muscles tugging on the optic nerve. And anytime if you had inflammation anywhere in the body and you then pressed on it or pulled on it, it would hurt. So it generally leads to some discomfort. The optic nerve appears normal when we look at it in about 2/3 of the cases. That's because the optic nerve, that's because the inflammation is behind the eye, affecting the optic nerve closer to where it enters into the brain space, or actually in the skull, but before it gets further back in the visual pathways. In about 1/3 of cases, the nerve is actually swollen. When we look in, we can see some swelling of the optic nerve. Children more commonly would get nerve swelling when they get inflammation unrelated to MS of the optic nerve. But in about 1/3 of the multiple sclerosis patients, the nerve will look abnormal. And the MRI is the greatest predictor for those individuals who are going to develop MS. So moving on, next slide. The characteristics is a central scotoma, which might be as illustrated here, a whiteout of central vision. There where you're looking, you might have your peripheral field intact, but you can't see right in front of you. And that central scotoma or blurred spot can fill up a larger area. And some people have, dramatic loss of their field. And but more commonly than what's shown here, it tends to be a gray out, as you'll see on the next slide, a gray out or a blackout of that vision centrally. But that's a central scotoma. Scotoma is our word for blind spot. Next. So on your left here, you have a normal picture of the optic nerve. And that's how we see it, the optic nerve. I don't have a pointer here that would project on here, but it's that little disc in the center, and then these vessels, which are these red lines coming out, are your arteries and veins that nourish the retina in the eye. Whereas in the lower slide to the right, this optic nerve is swollen. You no longer see these sharp, well-defined edges of the optic nerve, that whitish fuzziness all around that's actually blocking some of the vessels. That's a swollen optic nerve. So we'll see a papillitis or a inflammation of the nerve head in about a third of the cases of optic neuritis. Next. We can also see this in an MRI. Again, I don't have a pointer, but we're looking at an MRI of the eyes. You can see up front here, and in the image, the left eye, the one that's on the left of the screen, there's a little. The optic nerve is actually extending from the eye and going back towards the brain. But on the right side, you see that there's a bright white structure coming from the eye back towards the brain that you don't see in the one on the left. And that's actually your enhancing optic nerve from inflammation. That's optic neuritis. And just like the way when you have a new MS symptom elsewhere in your brain, you're going to get an enhancing plaque in the brain. This is your enhancing plaque in your optic nerve, so to speak. Next. So any of you who've had optic neuritis know that the outcome of an acute event is generally incredibly favorable. Over 90% of people get back to 20/40 vision or better. Now, if you get optic neuritis associated with NMO, because I know anytime we're speaking to MS patients, there's also people with neuromyelitis optica or NMO who kind of fall into the same category of a demyelinating disease. When patients with NMO get optic neuritis, the prognosis is much worse. A lot of people do not recover vision. The level of visual loss is often worse, and the amount of recovery is not nearly as favorable as patients with optic neuritis related to MS. And that sometimes when we work somebody up for NMO is when they have an episode of optic neuritis that doesn't improve, because that's just so unusual. But even if vision comes back to 20/20, a lot of times you'll find you still have complaints of contrast differences. You can't distinguish colors as well afterwards. You may still have an underlying pupil. The pupil may not respond as well because of loss of the actual nerve tissue. And we can see that on these OCTs, or optical coherence tomography, that I'll show an example of later. And after recovery, you can still have worsening of your vision when you're exposed to heat or exercise. And again, that's called UTOS phenomenon. One thing I stress, whether I'm talking to ophthalmologists, neurologists, optometrists, or patients, because you're the ones who are receiving treatment, we've known for 20 years, more than 20 years, that an acute episode, a new episode of optic neuritis, should not be treated with standard dose oral prednisone or steroids. And it's actually contraindicated. There's actually an increased risk of recurrent episodes of optic neuritis in people who were given standard dose prednisone in the optic neuritis treatment trial, which was really the study that was performed in the late 80s and was actually the first randomized clinically controlled trial in neuro-ophthalmology, and really led to a paradigm shift in how we treat patients, because that's where we first compared IV steroids to oral prednisone, which means by mouth, to placebo. And but to this day, I find that there's neurologists and every now and then ophthalmologists who are still giving either a Medrol dose pack or just oral prednisone in standard doses, like 80 milligrams a day for optic neuritis. So if you're ever receiving a prescription from from an ophthalmologist or neurologist along those lines, tell them, no, thank you, read this study. But IV steroids, on the other hand, or super high dose oral prednisone at 1,250 milligrams a day of prednisone by mouth, that can accelerate the recovery. But we learned from the optic neuritis treatment trial that IV steroids do not change the ultimate visual outcome. Next. So, how do we know who's at risk of developing MS after an episode of optic neuritis? Well, the answer is simply everyone's at increased risk of developing MS after an episode. But if you have multiple plaques on your MRI scan, more than 5, so not the optic nerve, but as all these little white dots in these MRIs down below, these are your demyelinating plaques or MS plaques. If you have greater than 5 of them at the time of your initial episode of optic neuritis, presuming you've never had an episode to suggest MS in the past, nearly 3/4 of the patients will develop MS at 15 years. If you have even just a single plaque in your brain, it's still about a little over 50% risk of MS at 15 years. But those individuals, even when we don't see any plaques on their MRI at baseline, they still have nearly a 1/4% likelihood of developing MS at 15 years. So the significant majority of individuals with optic neuritis without plaques on their MRI do not develop MS down the line. It still is a higher risk. And then if people are given disease-modifying agents right off the bat, that may well decrease those risks of getting recurrent events. Next. So after an episode of optic neuritis, here again we have our normal optic nerve on the left. Well, the optic nerve gets atrophic or pale. And so now you can see the swelling's gone. And even if it was the inflammation was behind the eye, a couple months after the episode of optic neuritis, the nerve will lose its healthy orange color and become what we call pale. So it looks yellowish white instead of orange. And in spite of the atrophy that we see, patients can still recover excellent levels of vision, even if they do have contrast sensitivity issues remaining. Next. So now we'll shift gears. I spent most of the time on optic neuritis because it is the most common symptom, not just for presentation with MS, but in all patients with MS in general. And again, as I said, as many as half the patients with MS, and that would apply to, I'm sure, a huge chunk of you in this audience today, do develop an episode of optic neuritis during the course of the disease. But double vision, probably less common. I'll make up a number, maybe 10% or so will develop double vision during the course of your illness. And something called an INO is the most common type of ocular motility disturbance or eye movement problem we see leading to double vision. Then you can have involvement of the cranial nerves. The 3rd, the 4th, and the 6th cranial nerves are involved with eye movement. And less commonly, we see patients with nystagmus who see jumping of their visual environment, or people who have what we call homonymous field defects. And those are visual field loss that affects each eye because of the problem affecting the brain, not the optic nerve, so further back. And moving on to double vision, if this is what an INO looks like to us. In the top left, we have a patient who's looking straight ahead. The eyes look like they're totally normal. But now when you ask the patient to look to the right, so that's the upper right side, the right eye moves out, but the left eye is not following it. So the left eye is not really moving in much. And that's a condition called an INO. And if the two eyes aren't looking in the same direction, you're going to see two images or double vision. So the eyes have to be yoked together perfectly. If the eyes are separated, even if they're overlapping, you'll see double. If the eyes aren't perfectly aligned and they shift off and one eye's going over to the side and the other is staying still, you're going to see two images. If you cover one eye, you'll see a single image. The other eye, you'll see single, but both you'll see double because the eyes aren't lined up. Now, if you go to the lower left, both eyes move fine when the person's looking off to the left. So they only see double really when they're looking off to the right in this case. Next slide. Now, we see INOs in other conditions as well. In the upper right picture here, we have somebody who suffered it from a stroke. So when we see an INO, the same eye movement disturbance here where the right eye is not moving in, but the left eye is moving out all the way, we think of a brainstem stroke in somebody who's 50 years of age or older. When you see this in a young patient, under 40, this is MS until proven otherwise, but sometimes myasthenia gravis, another neurologic condition, can mimic an INO. So we always think of that whether the patient's old or young. Next. The different cranial nerves, or the nerves that originate in the brainstem that move the eyes, can get affected in MS as well. Any nerve can. And so it's most commonly a sixth nerve palsy, and we'll see a picture of that on the next slide. And so it's the exact opposite of the INO. In this case, the right eye, when they're looking to the left, moves in normally, but the left eye doesn't go out. So whereas an INO, the eye doesn't move in, with the sixth nerve palsy, the eye doesn't move out. And that will also cause double vision because the eyes aren't lined up. Next. And what happens? Well, if the eyes aren't lined up, you're going to see two images. If the eyes are far apart, you're going to see them further apart. If the eyes are close together but not perfectly lined up, you'll see them like these two wine glasses. So a lot of you, if you drink these two glasses of wine, you'll see double, or you might just have a sixth nerve palsy. Next. So how do we get rid of double vision? And if any of you in the room have had double vision from your MS over the years, you know you can patch an eye like the shirt salesman in the lower left. You can use prism glasses as a means to get rid of it. You can even do muscle surgery like you do on kids with crossed eyes to straighten the eyes out if the double vision, if the eye movement has been stable for a long time, 6 months, 8 months, and isn't getting better. But like with most events of inflammation from MS, patients who develop double vision from an acute event like an INO, like a sixth nerve palsy, they generally get pretty much all the way better. And then some people can just ignore the second image. Most people can't, though. They're going to be miserable. They'll close an eye or want something done. Next. Nystagmus. Nystagmus is an involuntary jumping of the eyes. And so if your eyes are jumping up and down, you're going to see your visual environment jumping up and down. The eyes, you can have nystagmus, which is horizontal, means goes to the side. It can be vertical. It can even be pendular in some cases. And as a matter of fact, patients with multiple sclerosis, long-standing, kind of sometimes will get this little high velocity, this pendular nystagmus. You'll see the world jumping, and that can be extremely disturbing. We do have a couple medications that are helpful in ameliorating different types of nystagmus, and in MS, they can be employed as well. But often the nystagmus is highly disturbing to our patients when it occurs. Fortunately, it's rather infrequent. Next. Homonymous field defect. It's a funny word, but it means the same portion of the visual field is affected in each eye. So this is a diagram of a visual field, or what a person sees, and where it's white, they see. Where it's black or dark, they don't see. So if you get a MS plaque affecting further back in the visual pathways in the brain, if you affect the right side of your brain, that'll affect the left half of vision. It doesn't affect just the left eye like an optic neuritis. It only affects the vision in the eye that's involved. But because it's in the right half of the brain, it'll affect the left half of vision in both eyes. So it affects the left half of the left eye and the left half of the right eye, which is temporal portion one, the nasal the other. Next slide. So what you'll see, if this was your picture up above, your whole scene, but you had a hemianopia from involvement of the visual pathways in the back of the brain, you'll be missing half your vision. This is an example of how you would see if you had a right homonymous hemianopia, you'd be missing the right half of vision. And that can occur from involvement of the optic tract or the optic radiations and the occipital lobe. Next. Fortunately, that doesn't come up much. All right, now just a couple words on OCTs. OCT is optical coherence tomography. Here's a picture of an OCT machine. There's many different types on the market now. And now we'll look at some pictures on the next slide. What it does is the OCT actually takes an image of the optic nerve, and it'll actually, if here's your optic nerve, it'll take the measurement of the nerve fiber layer. The optic nerve is really an accumulation of individual nerve fibers. There are 1.2 million individual fibers that feed into this, and these fibers are nerve cells, individual axons, and these nerve fibers feed in from the retina into the optic nerve and form the optic nerve. So when we looked at that round little disc there, that was, even though that was magnified for those pictures, that is 1.5 millimeters in diameter, really tiny. And in that 1.5 millimeters are actually 1.2 million individual nerve fibers. So it's not just it's a single cord coming out, but it's really a cable. And so you can measure the thickness of the nerve fiber layer around the nerve. And if it's thin, that actually indicates a loss of the tissue. So this diagram here is looking at the, in color here, red, yellow, and green. That disc should be green all around. All those little clock hours should be green if it was normal. But when it gets thin from atrophy of the optic nerve, like when you saw that pale yellow nerve after the optic neuritis had resolved, we can actually measure the thickness. And we're going to talk a little bit about that now, because that's actually very helpful to us in a few settings, which will be described now in the next slides. So what we've learned is we always call MS a demyelinating disease or loss of the myelin sheath, but actually with OCT, we can show that it affects these ganglion cells, which are the nerve cells from the retina that form the optic nerve, and they atrophy or degenerate as well. Really, it's only in the eye that we can visualize a nerve. All our other nerves are either covered by they're in our skull, they're covered by our skin. The optic nerve is the one nerve in the body that we can directly dilate your eyes and look at. And because of that, we can directly measure the thickness of it and whether there's damage. And so now the question is, if we see progressive thinning of the nerve fiber layer via OCT, does this imply disease progression requiring more aggressive treatment? And does it predict outcomes in the clinical course? And does it predict the outcomes or clinical course? These are questions we have that we don't really know yet. Next slide, please. It takes 2 months after, approximately 2 months to see the thinning on OCT after an episode of optic neuritis. So what I typically do, a patient comes in with optic neuritis, I'll measure the thickness of their optic nerve at the time they present, and then I follow them and I do it again afterwards to see how much tissue was actually lost. And and you can actually use the thickness if you maintain at least 75 microns, not that I expect that number to necessarily mean anything to you, but of thickness at in a portion of the optic nerve at 6 months, that's usually correlated with good visual recovery. Next slide. And patients with the optic neuritis from NMO, though, as opposed to multiple sclerosis, tend to get significantly more thinning because the visual outcome is not nearly as favorable in NMO patients compared to MS patients after an episode of optic neuritis. The NMO patients can get all their vision back, but there's a much higher percent who are left with significant visual loss. Next. And what OCT can't do is you can't just do an OCT and determine, oh, because of this result, you're more likely to develop MS after your first episode of optic neuritis and someone who has less thinning. There may be a trend towards some increased thinning of the nerve fiber layer in patients who go into have MS, but there's no clear way to predict it just from OCT. Next. And some of the drug studies that are employed now for evaluating new medications for MS will actually require OCT as part of the protocol, with the idea being maybe if a patient had over the course of the study less diminution or less thinning of the nerve fiber layer with studied drug A versus placebo or versus another drug, then maybe it's showing that that drug has better efficacy in being neuroprotective or preventing ongoing demyelination and loss of nerve substance. So it is being used by drug companies, and if many of you have been in or any of you have been in drug trials, you may have received OCTs as part of the study protocol. I know I've participated in drug studies that did require it. Next. So I think we're getting to the end here, and we'll have Stuart come back on in a second. But I think it's really important, obviously, to be followed by a neurologist if you have someone in your respective community who specializes in MS, and certainly if you're having any visual issues related to MS, to have a neuro-ophthalmologist available with expertise in evaluation management of the ophthalmic manifestations of this disorder, and to recognize things which are atypical. So somebody else may, a general ophthalmologist or an optometrist, might make the right diagnosis of optic neuritis, but may miss some of the subtleties and might tell you that, wait, this is not typical for MS. This person should be worked up for NMO, and or it's not typical for MS or NMO and doesn't need because we'll get people, a neurologist might, on the other hand, who's not an MS specialist, think that all optic neuritis is similar and related to MS and get treatment for something they don't have. So it's important to be with physicians who are well versed in demyelinating disease. And I really want to thank everyone for attending tonight. And I'm certainly open to questions for as long as you want to go.
So thank you, Dr. Kay. That was an awesome presentation, and there are a lot of people online. I'm glad to see everybody there. So I want to thank everybody that is online tonight. And I did notice that a whole bunch of people came in just like in the last 15 minutes. And I'm sorry that you missed the beginning, but you know, the good thing is we are video recording this, of course, and it will be on our YouTube channel in, you know, less than a week. And we're trying to speed things up again because we are getting a backlog of programs now. So, but it will be on there. Listen, a lot of questions came in, and a lot came in by people typing them in online right now during the program. We had a slew of questions that people input when they were registering to be here. And hopefully I don't say anything more than once, but it might happen because I get MS, right? And I'll forget, and I might forget. But I want to let Dr. Kay know that even though you might have spoken about several things, there are questions that are asked that might replicate what you were talking about. We just have to let it go. You'll answer it again because there might be people online now that didn't hear the beginning anyway. Okay?
Right. It's always helpful to have the reinforcement, so whatever. And Stuart, you don't forget very much.
Well, I still have to say it, though. Okay. All right. All right, the first question. So we'll take one from online. I am going to say first names of everybody. Believe me, there's nobody on here tonight that doesn't have the same first name as somebody else somewhere in the world. But if you do, I mean, if you don't, I can't help that. All right. All right. First one is from A. Jessica. How often do you see ocular microtremors in MS?
Boy, that you even know about them is really interesting. That is a really, really, really rare ocular motility disturbance. And so an ocular microtremor, I think you could even ask other neuro-ophthalmologists who have never seen it. It's funny because I actually saw a case not all that long ago. It was probably the first one that I'd seen in years, and I had a resident with me and showed them. It is a very, just so people know, I'll move my, this would be if moving my hand, really gross movement. Ocular microtremor, I don't even think my video is picking it up. It's such a micro, small magnitude, amplitude, very fast movement that if you're just looking at the eye, you don't even see it moving. Under the slit lamp, that machine we use to magnify things, you can see this high velocity shimmering back and forth oscillation. And that's very troublesome to patients. So how often do I see it? It is rare. And then to be associated with MS, it is that much more rare and very uncommon, very little literature on it.
Okay, thank you for answering that.
Yeah.
All right, thank you, Jessica, for asking that. By the way, we're not going to stay in line with like all about this or all about that. The questions are going to move around. I can try to group them as best I can, but I'm not going to do so well with that tonight. Next question, totally different, from A. Jill. Can MS hasten the development of cataracts?
Nope. That was a quick answer.
Yeah, exactly.
Well, wait one last second. MS cannot, however, steroids accelerate cataract formation. So since MS patients are put on steroids, you can get a steroid-induced cataract. But the typical age-related cataracts, no. But from the use of steroids over the years, absolutely.
Okay, thank you.
Yeah.
Great, thank you. Optic migraine, is that a cause of MS or is it a cause of something else that people just think it's related to their MS?
Correct. It's just such a common phenomenon. If I'm talking, it says in the audience right now, there are 64 people there. I would bet no less than 10% of you in the audience have ocular migraines. But if I had 10 people in this room, at least one of us would. I've never had a migraine headache in my life, and I've had ocular migraines a couple of times. So they're very, very common, at least I'd say 10%, and just a coincidence that you happen to have MS too.
Right, and I have MS and I have optic migraine, and I can't stand the halo effect and the kaleidoscope and everything that develops with it.
And I just say enjoy the light show for 10 minutes as long as you don't get a headache afterwards.
That usually comes 30 minutes afterwards. Yep.
Yeah, so good time to take an. So if you, by the way, if you have ocular migraines and you get headaches with them, typically it'll occur after the the visual aura phenomenon resolves. So that's a great opportunity if you have migraine or with headache, take your Excedrin migraine at the onset of the aura, and that'll at least give you time to absorb it by the time the migraine would kick in. I don't know if that helps you, Stuart, but
yeah, no, I take something Riza something. I forgot the name of it.
I think that's one of the triptans, I think.
Right, that, yeah, and I usually take that as soon as the onset starts, and it really shortens the span of. Right. Okay, enough about me for now. Let's go to the next one. All right, Mary Lucia is saying, if you get double vision, does that mean you'll have it forever?
No. So just like most other episodes of demyelination, they're acute events. They come on and they usually resolve over a few months. That being said, with chronic disease, secondary progressive disease, yes, people can get double vision that stays. But the acute events, just like optic neuritis gets better over a few months, the double vision resolves as well.
Okay, thank you. All right, first off, that Jessica from earlier said thank you. And how do you treat the ocular microtremors?
There's so little literature on that, unfortunately. I mean, if you really look in the literature, there's probably, even though I've seen over the years a half a dozen cases or so myself, I think in all the literature, there's barely 10 cases out there. It's just so poorly described. I think your doctors, you can speak to your neurologists, you could see if things like gabapentin may help, or memantine they've tried. There's different things that have been tried for different eye movement problems or nystagmoid-like problems in MS, but microtremor is so rare, there is no medication that I could tell you has definitively been shown to be of benefit.
Okay, thank you for that. Next, from Brenda. And by the way, Brenda, haven't seen you online in a long time. Thanks for coming back. All right, Brenda is asking, I've had double vision for 7+ years and wear prism glasses for correction. Wondering if strabismus surgery might be an option for complete correction of the double vision.
Sure. So depending on the amount of deviation and the type of muscles that are involved, you should absolutely at least consult a strabismus surgeon. So the strabismus surgeons are eye muscle surgeons. So when Stuart, you actually said that word correctly, it is strabismus. So strabismus surgery is eye muscle surgery that's generally done by pediatric ophthalmologists. So you would want to call a local pediatric ophthalmologist, ask them if they do adult surgeries as well as the kids, because some strictly do peds, but most of them will do adults and pediatric, and go in for an evaluation. What I always say is, if you wear glasses anyway, so you have the prism glass in them, and if you're really nearsighted or farsighted, you're probably wearing your glass most of the time anyway. But if you're strictly wearing prism glasses, and otherwise could be doing well without glasses, you certainly would have a good motivating reason to pursue strabismus surgery. If it's a really small amplitude, the surgery is not as exacting as you'd like. But if it's the surgeon will tell you they're not going to do the surgery if they don't think they can help you.
Okay, thank you for that answer. Tahinder's writing, other than multiple sclerosis, what types of other things might cause nystagmus?
Oh, a million things, from strokes to age-related degenerations to toxicity from medications to tumors. A host of things cause nystagmus.
Okay, thank you. All right, and Julio's asking a question that I think that, well, I just saw a commercial for it the other day. Probably other people have too. But does the drug Vuity help people with that? I think they're talking about nearsightedness.
Yeah. No, what they're talking about is there's a quote new drug Vuity, which is pilocarpine. I'm pretty sure Vuity, when you're referring to it, is a new drug that they're talking about for helping people read up close. So yes. When people get over the age of 45 or 43, you start to lose your near vision. We call that presbyopia, and that's why everybody has to go and get their over-the-counter reading glasses if they otherwise don't read glasses. Vuity is actually pilocarpine. It's a reformulated version, but it's pilocarpine that we've used for 50 years probably in ophthalmology as a treatment for glaucoma. And they use a different strength than what was typically used before, in a different formulation, but it constricts the pupil and gives you a like a pinhole effect to read more clearly. But it's actually affecting, I guess, the accommodative ability of the muscle that we use for focusing up close. I have not had experience with it yet. I'm not yet a fan. What I always say, in things like this, it's so new it may not be true. Not that it may not help, but there's even been for years we always knew that chronic pilocarpine therapy increased the risk of a retinal detachment. I don't know if this drug will do that. I think it's so new that I'd wait and hear how the literature evolves.
Okay, thank you. Lisa writes, number 3, is it necessary to be rechecked for nerve thinking? I don't know why she said number 3. Maybe she had other questions.
Nerve thickness, probably she meant.
She wrote nerve thinning.
Oh,
Recheck
thinning.
the
I thought you
notes.
said thinking. I'm
Oh,
sorry.
sorry. If I did, it's because I couldn't read it correctly. So,
Yeah. So is it, you know, when patients come into me for their follow-ups, I do it out of my own curiosity. One of those questions that I had in the slide is, let's say, first of all, how reproducible is the OCT? Within a range, it's reproducible, but it's nothing you sink your teeth into. Like if you say, oh, it was 75 last year and this year it's 73, I'm getting worse. And it's not that exacting, 75, 73, 78. If you saw something going from 75 to 62, yeah, that's a big jump. That it's certainly more reproducible than a difference of 13. But I've seen it be somewhat technician dependent and vary in a day. But with a good technician, you can get somewhat reasonable reproducibility. And although I find it curious to see if we're getting progressive thinning, we don't really know if when somebody gets progressive thinning of their nerve fiber layer, should that mean, oh, maybe the drug's not working, well, we better switch to a new drug. If you're otherwise clinically stable, your MRIs have been stable, you're not having new events, I think we're still learning more about it, and I wouldn't necessarily go into a doctor, make an appointment just to get a follow-up OCT, although I do tend to do it on my patients when they come in.
correct. Lisa wants me to say thank you, and thank you for doing this webinar. It's very interesting. All right, we got a lot of people saying that. All right, but I'll just say it every now and then on here. All right, next one is from Darlene. Are there any eye exercises we can do to strengthen our eye nerves?
Nope. Nope.
Okay.
That's a quick one.
Yes, that's a quick one. Getting thunder here. Hopefully it is. We stay online.
No,
all right.
We're fine here in South Florida.
And I'm in Central. All right. Next one. Another word for me to try to make sure I get it out right is palinopsia. Palinopsia.
Palinopsia. Palinopsia.
Palinopsia. Got it. A symptom you often see.
So the answer is more frequently than saccadic microflutter or microocular oscillation, which, however, it was referred to earlier. So palinopsia is still very, very uncommon, but we absolutely see it. So palinopsia is a phenomenon by which when you move your hand across a field, and I don't know how it's coming out on the camera there, but actually almost looks that way, you get this trail-like effect and you see the previously seen image. So when they used to talk about the LSD trails, that's actually a form of palinopsia. It actually affected the area in the parieto-occipital lobe that produces it. So palinopsia, I maybe see a couple cases a year of palinopsia, where I've seen over 30 years, half a dozen cases of what we were calling microflutter. So still not common, but far more common. And it can actually be a drug effect too. If you're on Topamax, that can actually cause palinopsia in some cases, rarely. But
Okay, next one. Michael's asking, well, he's saying first, I have UTOFs and wonder how common this is with MS. So, yeah, that's all he's basically asking. He's got PPMS, and, well, I think you just answered, though.
Yeah, it's very common.
Okay. Nancy is asking, is a neuro-ophthalmic able to give a prescription for glasses?
I don't. So some do. So first of all, about 40% of neuro-ophthalmologists are neurologists. About 60% of us, like myself, are ophthalmologists. So the ones who are neurologists, although we would all give prism glasses. So what I do is I'll write down, even though I'm an ophthalmologist and used to refract every day for 3 years as a resident, I haven't refracted anybody in 2 decades plus. So you wouldn't want to get your glasses from me, but I measure for the prism, and then I'll tell the optometrist or general ophthalmologist to please refract, and I tell them how much prism to grind in. So between the two of us, we'll get people seeing. But some neuro-ophthalmologists absolutely prescribe glasses. So it's up to the individual what their practice pattern is. I do not.
Okay. Next, Elizabeth, here comes another challenging word. Would MS worsen my amblyopia and contribute to vision changes like double vision?
So no,
amblyopia?
and yes, that's true. That's true. Amblyopia. Amblyopia is what's commonly called a lazy eye, where you don't one eye never develop vision normally. So MS doesn't. Amblyopia is something you're born with. You develop it at birth, and if it's not corrected by the age of 5, 6, or sometimes maybe up to 9, it's going to stay the same throughout life. It doesn't change. MS in and of itself will not aggravate your amblyopia, but MS could affect the optic nerve that already has amblyopia in that eye and cause further degeneration, but it's not worsening the amblyopia per se. It's just you've got a superimposed effect of MS affecting vision from the optic nerve or what have you. And then the second part of the question, which was a yes. What was the last part of the question? Now I've got to check my memory. What was the last thing she asked?
I'm sorry, I didn't. I don't.
Already gone.
Yeah, I know. I already got deleted it because I thought you had it all, but
I did, and then I forgot. Well, the answer to this second part was yes. I remember thinking when I said no and yes, but I forget what the second question part of the question was.
All right. Well, if she can ask it again, then we'll get back to it. Okay.
Yeah.
All right. Sorry about that. I just thought it was a quick one, so I could get rid of it. So next, we have Lisa. And by the way, if I'm not saying it right, it's not because I don't know it, but maybe I need better glasses. All right.
Don't see me.
Okay, exactly. So Lisa is saying, now talking about glasses or something, Lisa is asking if an optometrist doesn't say I need to see a neuro-ophthalmologist, should I see you anyway? I've seen you a few times over the years, but how often do you recommend me to see you?
So, great question. And I've probably told you this, and when you've left my office in the past, that if you're having a problem related to your MS, I'm happy to see it anytime you call. You're a part of my practice. If the office ever gives you grief and said, who's referring you, you can just say you're a pre-existing patient of Dr. Kay's. Now, that being said, some patients know I know a lot more about MS and the eye than anyone else, so they want to come in once a year. I don't argue with people by any means or tell them don't come in once a year. Some people want to just see me for a full exam, and that's absolutely fine. What I usually say is coming and seeing me once a year isn't going to prevent something from happening to you 2 days later. And if I'm seeing you today and say you're good this year, nothing's going to prevent you from having a flare up in a week from now. And that's why I say it doesn't help you to come see me. But if you feel better getting to ask your questions once a year, I'm always open to seeing my patients. But I just figure you end up seeing enough doctors that you don't have to come in yearly. But if you want to check in every few years, you want to call the office, that's absolutely fine. But it's not like you need to see me.
Okay, thank you. All right, I'm going to ask you from now on to shorten the answers as best you can because we have a lot still to run through, and your family's waiting to see you for dinner. All right, I already got the phone call for me to get off the phone with you or get off the line with you so you guys can go eat dinner. All right. Okay. Yeah. Rhonda is saying, what is Rhonda saying? My screen just jittered. Am MS patient. I am an MS patient, and I have been using the glasses purchased at a pharmacy to read. Noticed I'm needing them more often. Which type of ophthalmologist, I guess, should I see or start to?
Any just a general ophthalmologist or optometrist in your neighborhood would be fine for just giving you a refraction and a good dilated exam. Let them know you have MS, and they'll do a full exam on you.
Okay, thank you. Next, from that was written in beforehand, what part of the brain is damaged or demyelinated to cause nystagmus and double-layered vision?
Yeah, so two separate things. Nystagmus, either the cerebellum, the short answer is things in the back of the brain. The brainstem or cerebellum problems there will cause nystagmus. And in terms of double vision, actually basically the same areas have the nerves that move the eyes.
Okay, thank you. Can you talk about Utah syndrome again and how common it is or not common for MSers? A person writes that when he or she gets UTOFs, when the body heats up, they can only see colors and no details.
Classic. Yeah. So it's just your core body temperature heats up, whether you're exercising out on the beach, what have you. And that disrupts the transmission, the axonal transmission along the optic nerve and just causes vision to be blurry. It's a very common symptom, especially if you've had optic neuritis in the past. And that's what it is.
Okay, thank you. Do you know anybody that, can you recommend a pediatric strabismus surgeon in Florida? Strabismus, I can't say it. Surgeon in Florida.
Yeah. Well, in the South Florida area, we have a few. There's at Bascom Palmer, there's Dr. Craig McCune, McKeown, or Dr. Hilda Capo. I think it's Louis Blumenfeld is in Orlando area, but you could just look up pediatric ophthalmology. And muscle surgery is what they do. That's their bread and butter. Anybody who's been doing it for any number of years should be totally adequate.
Okay, thank you. What are your thoughts on clemastine?
I don't have any thoughts on clemastine.
I actually thought it was that thing that looks like an orange. Clementine.
Clementine.
Okay. All right. I don't know. Maybe they spelled it wrong. Will damage from optic neuritis ever go away?
Any fixed damage that's there after the acute event stays.
Okay. Please tell us about macular swelling. How is macular degeneration related to multiple sclerosis?
So it's really not related to multiple sclerosis. Now, if those of you are on Gilenya or fingolimod, there is an incidence of macular edema or macular swelling, very uncommon. 1 out of a few hundred people will develop macular edema from fingolimod. But that's totally different from macular degeneration, which affects elderly population.
Okay, thank you. Next person, it's a long question. I believe I'm not really sure if I'm going to even say this right. Person Madeline is saying I have swelling in my eye. The eye doctor has been giving me shots in the eye every month for several years. Says I have to keep getting them. I stopped for I'm tired of them. Should I go back and restart them? The loss of vision that I first got is gone, so I need to go back, or should I need to go back or just wait till it comes back to lose the vision again?
You need to follow up with your retina specialist. I don't know what your particular condition was. Patients with MS can get inflammation in the eye, uveitis. I don't know if that's what they were treating you for or not. I can't comment on that.
Okay, thank you. Nancy writes, can you tell me if an MS patient has had optic neuritis? Can you tell me if an MS patient has had optic neuritis by the time I have gotten an appointment, problem has improved? Okay, so I've heard this from a few people now, and they're saying that, they have the optic neuritis or they have the nystagmus, and they're told to go see a neuro-ophthalmologist, but by the time they get there, it's all cleared up. And then what?
Yeah. So what I tell people is the following. Well, first of all, that's the good news, is that most of these acute events from MS, no matter what it's affecting, do resolve, at least in the early stage of relapsing or remitting MS. Now, if your doctor has given you a course of steroids and that's helped clear it up, that's wonderful. But it's not unreasonable to keep the appointment anyway, have a good baseline examination as long as you already have the appointment scheduled. And then should you get a new event in the future, you're already part of the practice, wherever that neuro-ophthalmologist is, and can get in to see them probably more quickly because you're already an established patient and now you're having a new emergency. So they're not going to do any. I wouldn't do anything. Sometimes I'll say, you know what, you think you're better, but there's a little bit left there. I think we'll follow it, and I'll see you back and make sure it goes away. Or I'll say, you're correct, completely normal exam. Now I know what you're like at your baseline, and we'll see if, I hope I never see you again. But if you have a problem, I'm open, I'm available. So I'd keep the appointments.
Okay, thank you. What current trials are going on to repair the optic nerve?
There's always things going on. You know, there's been a dearth of studies, unfortunately, with the pandemic, and there's nothing new and active going on down here in South Florida at Bascom Palmer. But there's always work going on, remyelinating drugs for MS in general, not just the optic nerve. There's some nerve growth factor studies, stem cell studies in the past. Nothing active going on, but there's always people interested in research and trying to come up with new drugs and studies.
Great, thank you. How does trigeminal neuralgia interact with the optic nerve?
It doesn't.
Okay, that answers that. All right, next, person writes, my eye doctor added a prism to my new lens. What a relief. My eyes are not as tired.
Great, and that's good. So they notice the eyes are imperfectly lined up, and you had a deviation. Now you're doing fine. That's great.
Great, thank you. All right, Karen writes, what is quivering of light in eyes? Is it MS?
I mean, a little, I'm not talking back and forth. If you mean a quick flash, a lightning flash in the peripheral retina, or the peripheral visual field is particularly at night, a little lightning flash, that's usually from vitreous traction, which is a gel in the eye tugging on the retina. That's not at all related to MS. If you get a burst of those, call your general ophthalmologist, or especially if there's new floaters, you have to worry about a retinal tear.
Okay, thank you. Cindy writes, with visual disturbances, auras that could look like optic neuritis, would or when would you consider looking into a PFO as a culprit? Patent foramen oval.
Patent foramen, yeah. So
Peyton.
There is some literature to suggest that people with PFOs have a higher incidence of migraine aura. I do know of an individual who had their PFO closed and they never got their aura again. There is some literature on that. That's really a question not for a neuro-ophthalmologist, but for a general neurologist and a cardiac surgeon. It really has nothing to do with MS per se.
Okay, thank you. Going back to the question that you couldn't remember, the second part of it was about double vision. But now I don't remember the first part to know about the second part.
I remember the answer was
yes. Yeah, that one.
The answer was yes, and whatever it was in terms of double vision, whether it could be related to MS or whatever, the answer was yes. I don't recall what they wanted to know about the double vision.
Right. Okay, next, Coy writes, what exactly is INO, internuclear ophthalmoplegia?
Ophthalmoplegia.
Yeah, there you go. And will it correct on its own? I relapsed a month ago and was told this is a lingering problem.
So, like other acute events in the relapsing or remitting course of the illness, in INO, when it comes on, it's a disconnect between the lateral rectus and the medial rectus. The lateral rectus moves one eye out, the medial rectus pulls it in. So if you can see me on the video, I'm looking to the right. I don't know if it's reversed in the video, my right eye is moving out, my left eye is moving in, and they're yoked together. That there's a connection that attaches these two muscles in the back of the brain called the brainstem. And when you get a plaque anywhere along that pathway between the two nuclei, you'll develop this problem. Usually it will get better, just like in any other demyelinating event, and usually get all the way better. That being said, it doesn't always get all the way better. So if it gets a lot closer, but not perfect, you might still have some lingering double vision way off to the side. It'd be uncommon not to improve at all and just to stay totally far apart. So it's usually going to get a lot better. and hopefully all the way better. If it doesn't get all the way better, you get prism glasses. In people with chronic, long-standing MS, we'll see people with INOs along with a bunch of other neurologic disturbances that are fixed and don't get better.
Okay, thank you for that. Next, we're winding down here, so we're going to get through these questions, starting to fly along. Person writes, Elisa writes, first I had uveitis, then I got MS. Many years later, is there a correlation?
There is. It's the old literature. When I trained, we were told that 2.8% of patients, that was the number that was quoted in the book, so roughly 3% of patients with MS had something called pars planitis, which is a form of uveitis. I don't think it's anywhere near that common. That being said, we've had many patients over the years who've either had MS and developed uveitis later, or had the classic presentation of having had uveitis and then getting MS. So there is a correlation. It's stated in the literature to be 3%. I think it's less than that, but it's certainly related, and we certainly see that.
Okay, thank you. Next question by Cindy. Could trigeminal neuralgia involving only the ophthalmic nerve be mistaken for optic neuritis? And how important it is to distinguish between the two in terms of treatment?
Got it. Now I see what that last question may have been driving at. So trigeminal neuralgia affects the fifth cranial nerve, or the trigeminal nerve, and there are three branches of it, and that's the in the ophthalmic division, the maxillary division, the mandibular division affecting the jaw. Trigeminal neuralgia rarely affects the ophthalmic division. It can, but it's very, very rare. It usually affects the maxillary, so it's a shooting pain under the eye in the cheek area or the mandibular region. Trigeminal neuralgia is a zap. It's a sharp, several second, lightning-like electrical, really uncomfortable pain, excruciating, but it comes for seconds at a time. And whereas the pain with and certainly trigeminal neuralgia occurs in patients with MS. It shouldn't at all be confused with optic neuritis, which is pain when you move the eye, whenever you move the eye, coming on acutely, sometimes occurring a couple of days before visual loss, and then followed by visual loss. It's just two totally different types of pain. And I can't see how that any doctor would confuse them.
I don't know, but I too get that sharp shooting pain, and it like you said, like lightning. And before I could even say ow or grab myself, it's gone.
That's different. So you're talking about a sharp shooting pain in the eye, split
like the ice
second,
pick.
gone, and it's an ice pick headache. So
That's right.
Ice pick headache commonly affects the eye, and it's like a sharp shooting stabbing pain. It is not trigeminal neuralgia. It hurts like heck, but and it just stuns you, and I get them myself. So it can affect the temporal area around the eye, commonly in the eye, just a sharp ice pick, and it's gone in a split second. That's very different from these like electric shock, debilitating trigeminal neuralgia pain, which really rarely ever affects the ophthalmic division of the trigeminal nerve. Not never, but it's rare. Yeah, right. Ice pick headaches, very common. I get them myself and just live with them.
Okay, thank you. And Karen, and another different Karen writes, what caused my eye that was affected by ON to occasionally, oh my gosh, tremor at the same rhythm as my heartbeat? What causes my eye? I don't know what she's saying. What causes?
Right. So she might be alluding to, there are certain people, unrelated to MS even, who can see their pulse in their eye. And I can't envision quite what they're seeing, but I've had a couple dozen patients easily yearly, maybe even a little more than that, who say, I see my heartbeat in my eye. And I don't think it would have anything to do with MS. And I've actually taken their pulse during it and say, tell me when you see a pulse. And they go, now. now, and it keeps perfect time with their pulse. So I don't know if that's what she has and whether that's even related to the optic neuritis, because I never had an optic neuritis patient complain of that, even after
good.
it resolved.
All right, thank you for that. So what do we got now? We have just a couple of questions left, so you'll be getting out soon, and I got to find it again. I don't know where it went. Excuse me. Okay, Q is writing, does MS aggravate floaters in the eye?
No, everything always has a caveat. The answer to the older age floaters, no, but uveitis, or inflammation in the eye, is characterized by the onset of floaters because you're actually seeing little inflammatory cells. So if you're one of the unusual patients, couple percent, and I think that's even a little generous at a couple percent of patients who get floaters from you or get uveitis with MS, that could cause your floaters. But the typical age-related single couple floaters here and there that go by, no relation.
Okay, thank you for that. And we're done. There were no more questions. Unbelievable. Yes, we made it through all that time, all right? But I do want to let you know that Rick says great information. Helene says good information. Glad that you were online. Brenda says thank you very much. I will seek strabismus, I can't say it again, strabismus, whatever surgeon in my area. Tahinder, thanks, Stuart. Angela, thanks, Stuart. Elizabeth, smiles to everybody and lots of good things. Lisa says another great webinar, and she loves watching these things. So I want to thank everybody for being here. I want to thank Dr. Matt Kay for being online tonight.
Glad I could help out.
And our next program, I don't even know our next program. We have so many, it's like crazy. I think we have Pilates coming up on Monday for those that are doing Pilates. And next week is just filled with other things going on. So we have, this MS Neuro TV series we're now doing once every other month rather than every month. And we're just picking up on online in-person programs again. And for those in South Florida, get onto the website. We got a program coming up live at the Signature Grand on April 9th with Dr. Brian Steingo. All right. And then we'll be in, where will it be? I don't know where we are. Anyway, we got live programs coming up all across the United States. So just go to the MS Views and News website. Everybody check out what's going on. If it's not live, we got virtual programs that happen every week. And we're just looking forward to seeing you all and getting you all involved. Dr. Kay, go have a good dinner. And I hope to see you soon on a good note, not a bad note, and not about the eyes, but about anything else. Okay?
Perfect.
Great. Good.
Take
have a good
care.
one. Good night, everybody.
Thank you.
Bye-bye.